Good afternoon. Welcome back to the afternoon session of the September 21st ACIP meeting. We'll begin with our next series of talks. We will start with disparities among COVID-19 epidemiology, and this will be given by Dr. Megan Wallace. Please, Dr. Wallace.
Good afternoon. Next slide. First, I'll present a brief update to the overall U.S. COVID-19 epidemiology. Then, I will present data on disparities in COVID-19 incidence, severity, and outcomes driven by the social determinants of health, and including disparities among racial and ethnic minority groups. Next slide. Next slide. As of September 20th, a total of 6.7 million COVID-19 cases have been reported to CDC. This map shows the cumulative case counts by county, with the darker red representing larger numbers of cases. Next slide. This figure shows the trend in the number of COVID-19 cases reported per day in the US, with the 7-day moving average in red. Nationally, cases peaked in mid-July and have been decreasing over the past 2 months. Next slide. This graph shows the number of specimens tested for SARS-CoV-2 using a molecular assay and reported to CDC by public health laboratories. The number of specimens tested are in the bar graphs, and the percent positives are shown in the line graphs. Nationally, the percentage of specimens testing positive for SARS-CoV-2 have continued to decrease since mid-July. This past week, the overall percent positive at public health labs was 4.5%. Next slide. This figure shows the specimens tested and percent positive among commercial labs reporting to CDC. Note the y-axis is different from the previous slide, as the number tested at commercial labs is substantially higher. The percentage of specimens testing positive in commercial labs has also been decreasing since mid-July. This past week, the percent positive was 4.8%. Next slide. As of September 20th, a total of 198,754 deaths due to COVID-19 have been reported to CDC. This map shows the cumulative number of deaths by county, with the darker purple representing larger numbers of deaths. Next slide. This figure shows the trends in the number of COVID-19 deaths reported per day in the US, with the 7-day moving average in red. Nationally, deaths peaked first in mid-April and again in early August, and have been decreasing over the past month. Next slide. This figure shows the trends in pneumonia, influenza, and COVID-19 mortality. The National Center for Health Statistics collects death certificate data from vital statistics offices for all deaths occurring in the United States. Based on death certificate data available as of September 17th, the percentage of deaths attributed to pneumonia, influenza, or COVID-19 for the week ending September 12th is 6.2%. And while lower than the percentage for the previous week, it remains above the epidemic threshold and will likely increase as more death certificates are processed. Next slide. As shared in previous ACIP meetings, certain factors such as older age and having certain underlying medical conditions increases a person's risk of severe COVID-19 disease. There is also increasing evidence that disparities in COVID-19 incidence, severity, and outcomes are occurring among people facing inequities in social determinants of health. Next slide. Social determinants of health are conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. These broadly include economic stability, education, social and community context, health and health care, and housing, neighborhood, and built environment. Next slide. The Social Vulnerability Index, or SVI, was developed by the CDC to identify communities that are at highest risk and may need the most support before, during, and after public health emergencies, such as a pandemic. It is a measure of social determinants of health using U.S. Census data and ranks each county and census tract on 15 social vulnerability factors and groups them into 4 related themes: socioeconomics, housing composition and disability, representation of racial and ethnic minority groups, and housing and transportation. Next slide. The map on the left displays the Social Vulnerability Index, with those counties displayed in dark blue having the highest vulnerability. The map on the right displays the COVID-19 cases per 100,000 residents, with darker red representing counties with the highest COVID-19 incidence. As you can see, these maps follow similar geographic patterns, indicating that many communities with high social vulnerability experience a high incidence of COVID-19. Next slide. Again here, the map on the left remains the same, and the map on the right now displays the COVID-19 deaths per 100,000 residents, with darker red representing counties with the highest incidence of deaths. Again, COVID-19 death rates also follow similar geographic patterns to high social vulnerability. Next slide. Using data from the Social Vulnerability Index, or SVI, and U.S. county-level COVID-19 cases from June 1st to June 25th, a recent analysis examined associations between social vulnerability and the risk of becoming a COVID-19 hotspot, and among hotspot counties, described incidents after hotspot detection by level of social vulnerability. COVID-19 hotspots are counties with rapidly increasing COVID-19 incidents, identified using standard criteria developed by CDC. SVI scores were categorized as quartiles based on their distribution among all U.S. counties, overall and by urbanicity. Counties in quartile 1, or Q1, have the lowest social vulnerability, and counties in quartile 4, or Q4, have the highest vulnerability. Next slide. This study showed that the probability of becoming a COVID-19 hotspot was 2.4 times as high among counties with the highest social vulnerability compared with counties with the lowest social vulnerability. This effect became even more pronounced in less urban areas. For example, in non-metropolitan areas, the probability of becoming a COVID-19 hotspot was more than 15 times as high among areas with the highest social vulnerability. Although not shown on this slide, this was particularly true for subscores related to racial and ethnic minority residents and housing composition, which led them to analyze these factors further. Next slide. This figure compares the relative risk of becoming a COVID-19 hotspot by components related to racial and ethnic minorities and housing composition. Results are presented by urbanicity, where associations depicted with circles represent large metropolitan counties, triangles represent small or medium metropolitan counties, and squares represent non-metropolitan counties. Counties at or above national median percentage of racial and ethnic minority groups had an increased risk of becoming a COVID-19 hotspot compared to counties below the national median percentage. You can see that the association was particularly pronounced in non-metropolitan areas, where the risk of becoming a hotspot was more than 8 times as high among counties with a higher percentage of racial and ethnic minority groups. Percentage of housing structures with greater than or equal to 10 units, or crowded structures, only increased risk of becoming a hotspot in metropolitan counties. And percentage of households with more people than rooms, or crowded households, increased risk more in non-metro counties. Next slide. This figure shows the incidence of COVID-19 among hotspot counties by Social Vulnerability Index quartile for the 14 days after detection as a hotspot. Compared with less socially vulnerable counties, quartiles 1 to 3, areas with the highest social vulnerabilities, quartile 4, continued to have markedly higher COVID-19 incidence. Next slide. There is increasing evidence that some racial and ethnic minority groups are being disproportionately affected by COVID-19. These disparities are seen in the disproportionate number of cases, hospitalizations, and deaths among these groups. Next slide. Racial and ethnic minority groups represent 40% of the total U.S. population, but nearly 60% of COVID-19 cases. This figure shows case-level data reported by health departments to CDC for approximately 5 million cases. The green bars show the percentage of the total U.S. population, and the blue bars show the percent of COVID-19 cases. Among Hispanic or Latino, Black, and multiple or other race groups, you can see that the percentage of cases in blue is higher than the percentage of the total population in green, indicating a disparity in COVID-19 cases among some racial and ethnic minority groups. Next slide. In another analysis among 79 U.S. counties identified as a hotspot, that is, counties with rapidly increasing COVID-19 incidents, from June 5th to June 18th, 76 counties had a disproportionately high number of cases among racial and ethnic minority groups. This figure shows the differences between the proportion of cases and proportion of the population in hotspot counties with disparities among racial and ethnic minority groups. For example, if a group makes up 20% of the population of a county on average, but 40% of COVID-19 cases, the difference would be 20%. The differences ranged from 4.5 for Native Hawaiian and other Pacific Islanders to almost 40% in American Indian and Alaska Natives. Next slide. Disparities in severe COVID-19 disease are observed by the differences in COVID-19 associated hospitalizations among racial and ethnic minority groups. This figure shows the age-adjusted cumulative rate of hospitalizations by week reported to COVIDNet, a population-based surveillance system collecting laboratory-confirmed COVID-19 associated hospitalizations in 14 states. As of MMWR Week 35, which is August 29th, hospitalization rates among American Indian and Alaska Native, Black, and Hispanic persons are more than 3 times the rate among white and Asian persons. Next slide. These figures show that racial and ethnic disparities in COVID-19 hospitalization rates among racial and ethnic minority groups occur in both young and older age groups. In younger adult age groups on the left, hospitalization rates among American Indian or Alaska Natives and Hispanic persons are higher, and in older age groups on the right, hospitalizations among Black persons are higher. Next slide. This figure is similar to the one shown previously, but now shows the percent of COVID-19 deaths in blue compared to the percent of the total U.S. population in green. Racial and ethnic minority groups represent 40% of the U.S. population, but nearly 50% of COVID-19 deaths. Among Black and multiple or other race groups, you can see that the percentages of deaths in blue is higher than the percentage of the total population in green, indicating a disparity in COVID-19 deaths among these groups. Next slide. This figure shows the differences between the percent of COVID-19 deaths and the weighted population distribution by race and ethnicity and age group from death certificate data. The bars represent different racial and ethnic groups. Bars above 0, highlighted by the red box, represent deaths in excess of what we would expect given the population distribution. Persons reported as Hispanic in green, Black in red, and American Indian or Alaska Native in yellow all experienced disparities in COVID-19 deaths in the age groups less than 65, with the greatest disparities observed in the youngest age groups. Next slide. This figure shows data on race and ethnicity by age group among a convenient sample of 10,000 COVID-19 deaths that occurred during February 12th to April 24th in 16 health jurisdictions. The median age was 71 years among Hispanic decedents, 72 years among all other race decedents, and 81 years among white decedents. The percentages of COVID-19 decedents who were less than 65 years and Hispanic or other race groups were more than twice those that were white. Next slide. Some of the many inequities and social determinants of health that put racial and ethnic minority groups at increased risk of getting sick and dying from COVID-19 include discrimination, healthcare access and utilization gaps, occupation and higher risk settings, education, income, and wealth gaps, and housing that is crowded or lacks basic services. A few examples of these inequities will be discussed in the following slides. Next slide. These figures show the proportion of total COVID-19 tests in the New York City population on the left and the proportion of white residents on the right. The percentage of COVID-19 tests increased significantly with the increasing percentage of white residents, as you can see in the similarity between the distribution of dark red and dark purple colors on the maps. Next slide. Some racial and ethnic minority groups are more likely to be employed in essential industries and in occupations with more exposure to infections in close proximity to others. For example, a study by Hopkins and colleagues showed that 38% of Black persons are likely employed in an essential industry compared to 27% of white persons. Next slide. This figure shows the association between poverty, representation of racial and ethnic minority groups, and COVID-19 rates, using data from 10 U.S. urban centers. Counties with more poverty, defined as those counties with a poverty rate above the median of the data set and depicted in the blue lines, had higher COVID-19 rates. These rates increased with increasing percentage of racial and ethnic minority groups. In counties with more poverty and a population that was more than 44.5% racial and ethnic minority groups, the COVID-19 rate was nearly 8 times that of counties with substantially white populations. Next slide. In a large health system in Louisiana, social determinants of health, such as residents in a low-income area and insurance type, were independently associated with an increased odds of COVID-19 hospitalization. Black race was also independently associated with an increased odds of COVID-19 hospitalization. Next slide. Racial and ethnic minorities are disproportionately impacted by the COVID-19 pandemic. Black, Native American, and Hispanic persons reported elevated levels of suicidality, depressive symptoms, and fear of COVID-19. Non-Hispanic Black persons are more likely to experience loss of a close relative due to COVID-19 than non-Hispanic white persons. And non-Hispanic Black and Hispanic persons are more likely to report food insecurity during the COVID-19 pandemic. Next slide. Next slide. As of September 20th, over 6.7 million cases of COVID-19 diagnosed and over 198,000 COVID-19 associated deaths have been reported in the United States. Racial and ethnic minority groups are being disproportionately affected by COVID-19, including increased risk of infection, hospitalization, and death. Inequities in the social determinants of health put racial and ethnic minority groups at increased risk of getting sick and dying from COVID-19. Next slide. Finally, I would like to acknowledge all of the CDC COVID-19 response teams that contributed to these slides today, particularly the COVIDnet hospitalization surveillance team, the hotspot detection team, and the Office of Health Equity. Thank you.
Thank you for that presentation. Now open for discussion questions. So I'll ask one. So you mentioned that there was a decrease in testing in recent weeks or months. Is that correct in one of your earlier slides?
A decrease in the percent positive.
Oh, I'm sorry about that. I'm sorry. I thought it was testing per se. Never mind. That's not it's a non-question. Any other questions? Okay. Then we'll move on to the next topic. There's one. Yes, we have several. Actually, this is Dr. Szilagyi.
Hi, thank you for a wonderful presentation, Dr. Walsh, and a very sobering depiction of the racial and ethnic disparities. I did have a question. In the slides where you showed large metropolitan areas, medium and small metropolitan areas, non-metropolitan areas, and the striking difference in the impact of social vulnerability, could you overlay that with the prevalent, like the total number of COVID cases or the proportion of all COVID cases that are in large metropolitan areas, medium and non-metropolitan areas? In other words, the non-metropolitan areas are at a higher risk from social vulnerability, but what is the sort of the total chunk of the pandemic in those three areas? Because so many people live in large metropolitan areas, far fewer live in non-metropolitan areas. You see what I'm getting at?
Dr. Szilagyi, thanks for that question. This is Sarah Oliver. Dr. Dasgupta is on from the hotspot team that worked on the social vulnerability analysis, if that is what you're referencing.
Yes.
Great. Dr. Dasgupta, do you have any kind of comments on Dr. Szilagyi's question? It looks like you're unmuted, Dr. Dasgupta. Are you able to answer? If not, we can. I mean, so the short answer is you're correct that there is a difference between kind of the concentration and people in kind of these more crowded conditions. Definitely they have more cases. I think when you look at the differences in population size, so incidence, kind of looking at the number of people in the population and the COVID, that disparity is greater. But I don't know that we have the specific data currently available to overlay, that and pull up right now, but we can certainly look into it.
All right, thank you.
Thank you, Dr. Oliver. Dr. Whitney Williams.
Thank you, Dr. Romero. Thank you for that presentation. Very sobering. Perhaps not on a national level, or maybe it could be done in a focused way, and that is to try to really dig down and understand if bias is playing a role in this. And what I mean by that is how many of these patients who died never made it to the hospital? How many of these patients were seen at a healthcare facility or by a healthcare provider and sent home? And then to look at it by ethnicity. And I understand that, this data may not, this data collection may not, or database may not have that level of detail, but the question is bias playing a role here? And I raise that as a question more than expecting an answer, but would appreciate any comments from the staff.
Thank you for that question, and we can definitely look into whether we have data to address that and get back with you. One of the things that I do think is interesting is many of the studies have found that once hospitalized, among a population that's already hospitalized, many of the disparities are not seen in death once they reach hospitalization. And so we're really seeing sort of the disparities in death driven a lot by the disparities in incidence. But I do think that there's probably more that we could look into there.
And this is, Dr. Oliver, I'll say from a surveillance standpoint, COVIDnet, they started as hospitalized, whereas I think Dr. Wortham's MMWR was deaths that had been reported from any site, so any kind of COVID-related deaths. So looking at the difference between those two would be a difference in the people hospitalized, but acknowledging your larger question that there is likely additional disparities that could come with lack of healthcare access as well.
I see that Dr. Dasgupta sent out a chat on the group chat. and that they had, I think they had connectivity issues. Can you answer the question now?
Yes, of course. Can you hear me now?
Yes, we can.
Okay, I apologize for that earlier. I was having connectivity issues. But to answer the gentleman's question from earlier, we actually did look at incidents in metropolitan versus non-metropolitan areas. And interestingly, during the summer months, there was actually a shift in higher incidence in less urban areas during the summertime. So incidence was higher in non-metropolitan areas as well as small and medium metropolitan areas compared with large metropolitan areas. And strikingly, SVI or social vulnerability scores were higher among those areas as well. And there was a shift in, I wish I could show you this particular image, but there was a shift in the proportion of counties with higher social vulnerability that were identified as hotspots in the summer months as well. And notably, for identification, these particular hotspot areas continue to have high incidence, particularly among socially vulnerable areas.
Thank you for those answers. Next question from Dr. Lee, please.
Thank you, Dr. Romero. Thank you for the excellent presentation. I was wondering how this information can inform our implementation efforts, and more specifically, do you anticipate we will be tracking vaccine distribution to these communities as a way to ensure accountability? I think it could be a really useful tool. I'm hopeful that it's feasible to consider this in implementation strategies regarding vaccine distribution.
This is Dr. Cohen. I can answer that. We have definitely been thinking about ways to use this type of data to help jurisdictions and commercial and private partners to ensure access and availability of vaccine in these targeted areas, as well as when vaccines available broadly. And so ensuring both access and demand will be really important, and I think also working with community and local stakeholders in these vulnerable communities will also be really important. So the answer is yes overall.
Thank you.
Thank you. Dr. Paling.
Thank you for this great presentation. As we are sitting here thinking about populations that need this vaccine and the timing, it raises the question about, has there been a sub-analysis of hotspots with incarcerated populations and in meatpacking plants?
So this is Dr. Oliver. There obviously there's specific groups within the response that are looking at these populations, and I think we've brought some of their data previously around kind of correctional facilities and some of the impact of cases within that have been associated with these workplace outbreaks. I don't specifically know about, further work that we could discuss right now or that we have available right now on, the hotspot detection related to those outbreaks, but acknowledge that has definitely been a part of, these counties that have been associated with outbreaks.
Thank you. Dr. Gluckman.
Yes, I appreciate the presentation. I thought it was great. One of the questions I have is, over time, I think that there have been some advances in therapy, and is it possible that over time we can see some reduction in the disparities in valley rates, so that perhaps communities that were impacted very early had higher mortality rates and greater disparities?
Yes, thanks for that question. We're going to continue to follow and see how things progress and gather those data and hopefully we will see reductions.
Dr. Freihofer.
Sandra Freihofer, American Medical Association. Thank you so much for presenting this data. And these disparities are both striking and disturbing. I know that the FDA on June 30th issued special guidance for the vaccine makers to include diverse populations in all study phases. But as we heard earlier today, of the two studies that ACIP, the two vaccines ACIP has reviewed, one is only at 28%, the other is at 26%. I understand that one of the groups is trying to increase its study participant size up to 44,000. But should we really be doing more to push that percentage to more compare to what the general population, the 40% of racial and ethnic minorities that we see in the general population? And are there any additional things that we need to be doing now to instill confidence in these racial and ethnic minorities so when there is a vaccine available, if it looks like it's one that's going to work well, depending upon the characteristics of the vaccine, will they be willing to take this vaccine?
Thanks. This is Dr. Oliver. I will say that we have continued to reiterate the importance that the composition of these clinical trials mirror the population of the U.S. So ACIP and in discussions with FDA and manufacturers have continued to reiterate the importance of that.
And this is Dr. Cohn. I'll follow up on the question about increasing confidence. Absolutely, it will be critical to the success to the success of the vaccine program to ensure that all individuals, including racial and ethnic minorities, are confident in getting the vaccine. And I think there's two components of it. One is we've invested in trying to implement community-level engagement around influenza vaccine, and we're hoping a lot of the work that we've done in that space will help us with COVID vaccine engagement. But from everything we've learned over the last year, it is imperative that we engage communities at the very local level, in addition to ensuring that our messages are culturally competent and targeted and empathetic, but also clear and accurate in terms of the information we provide. I think our efforts to increase vaccine confidence will expand more rapidly as we have data coming back from these vaccines to incorporate into our messaging. Right now, as we think about messaging, it's very broad because we don't have, it's more in the preparation phase, but when we have safety data, we can message, and when we have efficacy data, we can message. That will be a big push, is to ensure that these communities are understanding these messages and hearing it from people who they trust.
So, Dr. Cohn, if I may add additional comment to that, this is Jose Romero. So that messaging has to begin now. It cannot wait until the vaccine is clearly on the precipice of being released. I can only speak from my experience, and that is that within the advisory groups that advise the Arkansas Department of Health that are from underrepresented minorities, there is extreme disconfidence in this vaccine. Disconfidence. I have been trying to reach out to the Latino population primarily by having specific targeted talks to leaders of that group. I think we need to begin to do that now if there is to have any sense of confidence in the vaccine among these minority populations. So I'll stop there, and then thank you, Dr. Freihofer, and then Dr. Arthur.
Thank you for the presentation. I actually just wondered if it would be helpful to have some breakdown of the racial and ethnic differences in the different populations by metropolitan area and not metropolitan area. I just wonder if there's enough data to see the composition of the racial breakdown within those three spaces within the data that was shared.
Thanks for that question. We can take a look at that and whether or not we have that data available and get back with you.
Yes, and Sharda Dasgupta, I am looking at the racial breakdown now, and there are more likely to be racial ethnic minorities in medium and small metropolitan areas, as well as compared with large metropolitan areas, but I'm happy to answer more questions about that later.
Thank you. Dr. Fry.
Thank you for taking my question. I also wanted to comment and I guess jump on the bandwagon, if you will, with Dr. Fryhofer and Dr. Romero. And I agree that we need to be extremely proactive. I mean, as a country, not us as individuals here on this call, but we need to be very proactive in our educational pieces to reach out to our racial and ethnic minorities, our essential workers, and people of low socioeconomic means to do the educational pieces that are necessary to be able to have individuals confident with taking vaccine and everything that's related to that. And this may be an inappropriate question, or I'm not sure, but I'd like to know who actually does this work and at what level is it done and what kinds of efforts are being made and when will they start. And I don't know if it would be appropriate for us to see in a future presentation some of the activities that are being undertaken. That's all I have to say.
This is Amanda. Yes, thank you for that. I think it is not. There's not a single entity. There are multiple different entities that are that will contribute to activities to increase confidence at the state, local, tribal, community, non-governmental partners, governmental partner level, and we are continuing to refine those activities. And I think we hear the message that this work needs to begin now, and it is beginning in many communities. But we understand and we'll think about that. Thank you,
Dr. Eckert.
Thank you. This is Linda Eckert with the American College of Obstetrics and Gynecology. I wondered if you had any data about the pregnancy status of the patients that you presented, of the women in the disparities data and the maps, so that we could see if the same trends were following for pregnant women.
Thanks for the question. This specific issue is one that we're looking forward to addressing at a future ACIP meeting, hopefully upcoming very soon. So we don't have that on the data that we can present today, but we're working on putting that together to present to ACIP soon.
Dr. Cohn?
I just want to correct the record. Dr. Dasgupta inadvertently misspoke earlier and wanted to let everyone know that there is a larger proportion of racial and ethnic minorities in larger metropolitan areas compared with smaller, less urban areas. And I think some of us were confused by that, but thank you for that clarification.
Thank you. Dr. Lee.
Thank you. I wanted to take a moment and, just recognize our CDC colleagues who we know are working incredibly hard behind the scenes to stand up multiple systems and communication processes in this climate. And it's extremely challenging. And just to acknowledge that we know that you're working harder than ever. So with that said, I did want to perhaps reframe the suggestion, at least in the interim, which is I agree that it's challenging to communicate around vaccines and vaccine confidence without actually having the clinical trial data in hand. But I still think that perhaps one thing that we can do together is to continue to emphasize the process for decision making and how much emphasis we're all placing on transparency and the importance of that. we are definitely going to need our trusted voices, providers, community leaders, and others to feel confident in vaccines. And so I hope that also working with liaison organizations going forward, this will continue to be a strength of this group, which I recognize again that this remit goes well beyond ACIP, but wanted to just acknowledge and thank our CDC colleagues for how challenging this effort is, and that I hope that we can all work together to be able to support what's needed. Thank you.
This is Dr. Messonnier. Thank you, Dr. Lee. And, I'd like to take the opportunity to thank all of our stakeholders and partners. This is a challenging time for all of us. I think we all believe that COVID vaccine could be a really important part of the solution, and the groundwork that you're discussing laying is going to be really important to make sure that people are ready and willing and confident when those vaccines become available. So I think we agree with you completely. Thank you.
I don't see any new hands, but I just want to run through the list. There's still some hands standing or up. Dr. Gluckman, Dr. Bell has a question.
Thank you. Actually, I was more or less going to say exactly what Dr. Lee just said, but since I have the floor, I'll ask a somewhat smaller technical question about the Social Vulnerability Index. I like the idea because it integrates so many different factors and it ties so closely to the geography. And I'm just wondering if the extent to which anyone at CDC is working on implementation thinks that it's feasible for localities to use the Social Vulnerability Index as a tool in their implementation planning.
This is Amanda. I think it's quite feasible, and as you heard from the earlier presentation regarding Tiberius and the tools that we're using to help with local and jurisdictional planning, these factors can all be incorporated to provide information to programs to help target their efforts. And as all of you know, local and state programs know their communities frequently even more than data can show, but I think combining their expertise with the power of understanding some of this data on social vulnerability indexes is really important and will be implemented. Thanks.
Dr. Foster.
Thank you for all of these presentations. They've been excellent. This really, I'm not sure to ask this question because I'm not sure this is the proper talk to ask it, but one thing that we hear an awful lot, and this has nothing to do with the racial ethnicity issues, is compliance with our behavior compliance with the degree of protection, the masking, this type of stuff. Are we looking at all where the people are actually, who have the cases where we're actually trying to protect themselves or not trying to protect? I see a lot of people that actually say, I don't believe this stuff, I'm not going to wear a mask. Have we looked at that?
Hey, this is Dr. Oliver. There are definitely aspects within the response that have looked at that broadly. We haven't necessarily brought that to ACIP directly, but I do think that there's communications and messaging on CDC's homepage that could answer that or help address that.
Ms. Bata. Ms. Bata, your hand is still up.
Sorry, I forgot to unmute.
Go ahead.
I think that Dr. Lee eloquently talked about a lot of what I wanted to say. And I think that being on the local side of the planning, we know what venues, what avenues we can use to provide messages, but I think that there is so much national messages right now that it's very difficult to provide the context around what is really happening. Again, I think this has been mentioned previously, the title Operation Warp Speed scares a lot of people. And so I think it would be helpful if our national leaders in the FDA and at CDC could talk about what that means in plain language. So, and we can certainly amplify that message. We're happy to, but I think that being able for people to visualize what this means might help begin to assuage some of the anxiety that we've been hearing about vaccination for COVID-19. Thank you.
Thank you. Dr. Glutman, your hand is still up. Do you have another question? Are there any other questions? Okay, we'll move on to the next presentation by Dr. Oliver on the overview of vaccine equity and prioritization frameworks. Dr. Oliver.
Thank you. Good afternoon. Next slide. So ACIP has discussed the inclusion of an ethics and equity principles as a part of the process to identify proposed groups for early COVID-19 vaccination. As a first step, the work group reviewed frameworks and published literature related to COVID-19 vaccine allocation. Next slide. Several groups have published frameworks for early vaccine allocation, including the WHO's Strategic Advisory Group of Experts, or SAGE, the Johns Hopkins School of Public Health, and the National Academies of Science, Engineering, and Medicine. And we'll go through each of these three shortly. Next slide. So first, for an overview of the WHO SAGE values framework for the allocation and prioritization of COVID-19 vaccination. It includes both national and global considerations with the 6 core principles listed here. Next slide. In this framework, the priority groups were not ranked and were relatively broad. They include populations with significantly elevated risk of being infected, such as healthcare workers, employment categories unable to physically distance, or persons living in crowded conditions. They also include populations with elevated risk of severe disease or death, including older adults, groups with comorbidities, and socioeconomic groups at disproportionately higher risk of severe disease and death. Next slide. So next, moving to the Johns Hopkins Interim Framework for COVID-19 vaccine allocation and distribution in the US, with a purpose to identify candidate groups for serious consideration as priority groups and demonstrate how ethical principles and objectives can be integrated to produce an ethically defensible list of candidate groups. The authors note the importance of transparency and a fair process, equity, including access to healthcare, and community outreach and engagement. Next slide. The structural organization of the Hopkins Framework includes 3 ethical values linked to 7 ethical principles. These are then linked to 11 policy goals, which are linked to 12 objectives, which ultimately lead to the priority groups. Next slide. While we can't go into detail on each level, the 3 ethical values and 7 ethical principles are shown here. The ethical values include promoting the common good, treating people fairly and promoting equality, and promoting legitimacy, trust, and a sense of ownership in a pluralistic society. Next slide. The priority groups for Tier 1 are shown here. First, for those most essential in sustaining the ongoing COVID-19 response, including frontline healthcare personnel caring for COVID-19 patients, frontline emergency services personnel, vaccine manufacturing, diagnostics, and public health workers. Next, to those who have a greatest risk of severe illness and death and their caretakers, including adults 65 years of age and those who care for them, others at increased risk of severe disease, frontline long-term care facility providers, and healthcare personnel caring for patients with high-risk conditions. And finally, included in Tier 1, those essential to maintaining core societal functions, including public transportation and food supply workers and teachers. Next slide. Next, these are the groups included in the Hopkins Framework's Tier 2. These involve broader health provisions, including other healthcare personnel and pharmacy staff, those who face access to care, including those living in remote locations, those needing to maintain other essential services, including deployed military, police, and fire, and finally, those whose living or working conditions give them an elevated risk of infection, including those living in congregate settings. Next slide. And finally, the National Academy of Medicine's discussion draft of the preliminary framework for equitable allocation of COVID-19 vaccine. They define their purpose to develop an overarching framework for vaccine allocation to assist policymakers in domestic and global health communities in planning for equitable allocation of vaccines. They note the expectation that the framework will inform decisions by health authorities, including ACIP, and they were asked to consider criteria for setting priorities for equitable allocation and how to apply the criteria to determine the first tier of recipients. Next slide. The National Academy Framework structure is listed here with an overarching goal to allocation criteria and allocation phases. They have foundational principles listed here: maximize benefit, equal regard, mitigate health inequities, fairness, evidence-based, and transparency. Next slide. They state that their overarching goal is to maximize societal benefit by reducing morbidity and mortality caused by the transmission of COVID. Their allocation criteria are based on the risk of acquiring infection, risk of severe morbidity and mortality, risk of negative societal impact, and risk of transmitting disease. Next slide. Their vaccine allocation phases are listed here. Phase 1A, or a jumpstart phase, is listed as the high-risk workers in healthcare facilities and first responders. Phase 1B is people of all ages with underlying conditions that put them at significantly higher risk, defined as 2 or more CDC-designed designated medical conditions, and older adults living in congregate settings. Next slide. Phase 2 includes critical workers at substantial risk of exposures, teachers and school staff, people with any underlying condition, all older adults, people in homeless shelters or group homes, and people in prisons, jails, or detention centers. Next slide. Phase 3 includes young adults, children, and the remainder of essential workers, with Phase 4 as everyone not previously vaccinated. Next slide. So to put these together in one table, organizing by the 4 groups ACIP has previously discussed: healthcare personnel, other essential workers, adults with underlying medical conditions, and adults 65 years of age and older. The WHO priority groups include all 4 of these populations, but are unranked, so further details are not able to be provided. For healthcare personnel, both Hopkins and NAM have frontline healthcare personnel in tier or phase 1, with others included in the next tier or phases. For other essential workers, you can see there's substantial diversity among these groups through the frameworks. Teachers and school workers, here in blue, are in tier 1 with Hopkins, but phase 2 with NAM. And police and fire, shown in red, are tier 2 with Hopkins and phase 1A with NAM. For adults with underlying medical condition, Hopkins included all in tier 1, and NAM includes those with 2 or more underlying conditions in phase 1B, and adults with 1 underlying condition in phase 2. For adults 65 years of age and older, Hopkins includes them in tier 1, and NAM includes those in congregate settings in phase 1B, and others in phase 2. Next slide. So this slide presents the ACIP workgroup interpretation of the frameworks when they were presented and discussed. First, all published frameworks identify healthcare personnel as important for early phase vaccine allocation. However, after healthcare personnel, all frameworks have large population sizes for the next phase or tier, with both likely 50 million individuals or more, which may be more than the initially available allocation vaccine doses. The workgroup also felt that many of the identified populations contain operational or implementation difficulties. For both frameworks, essential workers are split across different tiers or phases, which could be difficult to implement. In addition, the identification of individuals and delivery of vaccine to only those with 2 or more underlying medical conditions would be very difficult to operationalize. And finally, both frameworks separated out frontline healthcare personnel from other. However, the epidemiology of COVID-19 disease among healthcare personnel demonstrate that cases and risk of disease extend beyond only frontline healthcare personnel. Next slide. Using input from these prior frameworks, ACIP has worked to develop their proposed ethics and equity framework. So I'll lay out this proposed framework next. Equity has been considered as a cross-cutting of all 3 of the frameworks reviewed previously. Hopkins discussed the importance of promoting equity and social justice. The National Academies discussed using CDC's Social Vulnerability Index, which was just presented. And the WHO stated that these vaccines should contribute to equitable protection of people around the world. Next slide. In that line, ACIP has proposed an ethics and equity framework for COVID-19 vaccine allocation. The purpose of this framework is to assist ACIP in the identification of early recipients for allocation of COVID-19 vaccine in the setting of constrained supply. The goals are to minimize death and serious disease, preserve functioning of society, reduce disproportionate burden on those with existing disparities, and increase equity of opportunity to enjoy health and well-being. Next slide. After discussion with subject matter experts and with the ACIP workgroup, these are the 5 proposed ethical principles for the ACIP Ethics and Equity Framework. They include to maximize benefits and minimize harms, equity, justice, fairness, and transparency. I'll explain each principle further next. Next slide. First, to maximize benefits and minimize harms. This includes minimizing death and serious disease, to address our obligation to promote public health and promote the common good, balancing with our obligation to respond and care for persons, and based on the best available science. Next, for the equity principle, this will help orient discussions to make sure that vaccine allocation reduces rather than increases health disparities, and to ensure that everyone has a fair and just opportunity to be as healthy as possible. Next slide. Next, the justice principle involves a commitment to remove unfair, unjust, and avoidable barriers to good health and well-being that disproportionately affect the most disadvantaged populations, and that interventions must intentionally ensure that groups, populations, and communities affected by a policy are being treated fairly. Then the fairness principle is a commitment to fair stewardship in the distribution of a scarce resource, with equitable distribution of benefits and burdens, not exacerbate existing disparities in health communities, and equal opportunity to access vaccine, and consistency in implementation. Next slide. And finally, transparency, supporting that the principles and process for allocation decisions are clear, understandable, and open for review. This involves, to the degree possible given the urgency of the response, public participation in the creation and review of the process to be recognized and honored, emphasizing that it is essential to build and maintain public trust during planning and implementation, and that all recommendations are evidence-based, with information used to make recommendations be publicly available. Next slide. All ACIP recommendations for COVID-19 vaccines must be ethically principled, evidence-based, and feasible for implementation. Next slide. GRADE and the ETR framework will be used to ensure that recommendations are evidence-based. Dr. Dooling's upcoming presentation will have further discussions around whether recommendations are feasible for implementation. So the remainder of this talk will focus on the steps taken to make sure ACIP recommendations are ethically principled. Next slide. So the next several slides will use this table to walk through the 4 populations discussed previously using the proposed framework. Subject matter experts in the work group felt that the transparency principle was more about the process than each individual population, and as such would be more of a foundational principle across the entire framework. In addition, the fact that all ACIP recommendations are evidence-based is an overarching principle as well. Next slide. So first, for healthcare personnel, under maximize benefits, healthcare personnel are essential for the response. Protecting healthcare personnel may decrease transmission to patients, coworkers, and the community, and may decrease morbidity and mortality among this population. We know that nearly 40% of healthcare personnel have a high-risk condition or 65 years of age and older, and they may serve in low redundancy jobs where absenteeism may compromise care. Under equity, there is an overrepresentation of some racial or ethnic minority or lower income earners. The seroprevalence is higher among Hispanic and non-Hispanic Black healthcare personnel, and a larger proportion of staff at long-term care facilities are female, non-Hispanic Black persons, and disproportionately lower wage workers. Under justice, healthcare personnel should have equal opportunity to access vaccine. In addition, the definition of healthcare personnel is broad and includes both paid and unpaid persons serving in healthcare settings. Under fairness, vaccination of healthcare personnel could help reduce disparities in health outcomes based on the inequities just discussed, and it acknowledges the increased risk of exposure due to their nature of work. And finally, transparency will involve engagement with partners and key stakeholders, as well as discussion at public meetings. Next slide. So next, moving to other essential workers. Under maximize benefits, their work is essential for the response or functioning of society. Protection may decrease transmission to work and community contacts, and it could decrease outbreaks in some work settings or sectors, as was discussed previously with food and agricultural plants and correctional facilities. Under equity, there is an overrepresentation of minority groups in some sectors of essential workers, with racial or ethnic minority populations representing nearly 90% of cases in meat or poultry processing plants, and 73% of cases in workplace outbreaks in Utah. Under justice, workers should have an equal opportunity to access vaccine. Under fairness, the vaccination of essential workers could help reduce disparities in health outcomes based on the inequities discussed. And it also acknowledges the increased risk of exposure due to work and the inability to work remotely. And transparency remains a foundational principle. Next slide. So next, adults with high-risk medical conditions. Under maximize benefits, protection among adults with high-risk conditions could reduce morbidity and mortality. 60% of hospitalized adults and 80% of adults who died had 3 or more underlying medical conditions. Under equity, racial and ethnic minority groups have increasing prevalence of many high-risk conditions, with data on obesity presented here. In addition, the prevalence of underlying medical conditions is higher in counties in the southeastern United States and rural communities, where the social vulnerability index is generally higher. Under justice, persons recommended for early phase vaccination should have an equal opportunity to access vaccine. And under fairness, providing vaccine to adults with high-risk medical conditions can help reduce disparities in health outcomes. And transparency, again, is a foundational principle. Next slide. And finally, for adults 65 years of age and older, under maximized benefits, providing vaccine to this population could reduce morbidity and mortality. Adults 65 years of age and older represent 16% of cases, but nearly 80% of deaths. However, there are other things to consider in this population. Under equity, Hispanic and non-white decedents are underrepresented among COVID-19 deaths in adults 65 years of age and older. Under justice, the HHS Office for Civil Rights says a strict age cutoff or age-based criteria alone is not recommended for use in ventilator or resource allocation. Under fairness, another article on the ethics of vaccine allocation stated that a healthy older person who can shelter in place is at different risk from a medically vulnerable person in a crowded setting. And the American Geriatric Society submitted a statement to NAM after their framework was released, stating that age should never be used to exclude someone categorically from a standard of care, nor should age cutoffs be used in allocations. This public comment shows the importance of transparency as a foundational principle as well. Next slide. So the next steps are continue to progress the development of an ACIP ethics and equity framework, and we're happy to receive input from ACIP regarding the 5 proposed ethical principles and allocation. We also plan to have further discussions around how to apply this framework to phase 1 allocation discussions and future recommendations. In addition, there are discussions around how ethics and equity could formally be incorporated into the ETR framework for COVID-19 vaccines and potentially broader to other vaccines as well. Next slide. We had much help putting this ethics and equity framework together, primarily a core team of Mary Chamberlain, who helped lead these discussions, Kathy Kinlaw as our ethics subject matter experts, and Dana Bowen-Matthew as our subject matter expert for health equity. Next slide. Thanks, and happy to take any questions or input into the proposed ethical principles.
Thank you very much. Presentation is open for questions or comments. Peter, Dr. Szilagyi.
Yeah. First of all, thank you for an incredibly clear presentation, as always, Dr. Oliver. I just want to lend my support to the framework and the ethic and the 5 major ethical principles: maximizing benefit and minimizing harm, equity, justice, fairness, and transparency. I think these are the right principles. They also, I think, take the best components of the SAGE, the Hopkins, and the NAM models, and actually the principles overlap very closely with the ethical principles from those models. I think one of the challenges that we're all facing, and this feels very much like a Solomon's choice, we do have to remember that over months, the vaccine supply will go up. So what we're really talking about is making these decisions for a shorter time period. One of the challenges that I feel and that we all feel, I think, is a wide diversity in risk within each of these groups. So even within the healthcare group or the essential workers or those with chronic conditions, there's really wide diversity in risk, but it's really difficult to actually figure out the risk for an individual person. And we need some sort of a principle that follows the rules of simplicity and the ability to identify individuals. But overall, I want to just emphasize that I support the principles, and I think we're going in the right direction, as difficult as this is.
Thank you.
Thank you. Dr. Bell.
Thank you. I just actually thank Dr. Szilagyi for your comments, and as the work group chair, I really would encourage other ACIP members and liaisons to also weigh in on your sense of whether this is heading down the right track, and if how you feel a framework like this might help us or not. I think this is something that we've been focusing on quite a bit. There's obviously been a lot of other groups that have been publishing these kinds of frameworks. And while I totally agree with what Dr. Szilagyi said about, we don't want to be so totally focused on what is actually something that hopefully will last for a relatively short period of time. I think to our comments earlier about public confidence, showing that we've really thought about all of these issues very carefully and are transparent about it, I think is really helpful for inspiring public confidence. So I hope others will help us by letting us know what you think about this this framework.
Dr. Paling.
Thank you, Dr. Oliver, and your entire team for this very clear and thoughtful presentation. I agree. This is exactly the type of information we need to think clearly about how do you maximize the benefit and minimize the harm. This is a very transparent way to do it, and I agree with all 5 of the principles. I think it is an excellent start and look forward to the work to come.
Dr. Hunter.
Yeah, I agree with the principles. I think this is a great outline on the topic. Couple of comments is one, I think that it's important that we're looking at how and who's going to apply these principles early on, and that it's hopefully not going to be the individual clinician or nurse at this point of care dealing with an individual patient or client, but would rather be on a more programmatic level at the state level, the local health department level, the healthcare system level, that these principles would be applied to select the venue, and that there would be more flexibility to decrease any potential conflict at the point of care between the actual vaccinator themselves, so that there can be some flexibility at that site. Secondly, I think that in order to increase confidence in general with this, we need to really, and in order to gain trust and cooperation, we really need the political leaders and scientific experts coming to a consensus behind this. And so it'd be really, I think that effort is going to make our job in ACIP and at state health department levels much easier, because, if there's a unified delivery of these messages that evidence-based interventions are the way to go, and using these ethical principles are the way to go, it's going to make those where the rubber meets the road at the state health department level, selecting the venues, and when the nurse or clinician is right there at the point of care, that's really going to take the load off of the interaction there. So I'd really, as a public health practitioner and clinician myself, I'd really very much appreciate as much help as we can get at all levels of political leadership and public health leadership to get behind these principles and support evidence-based interventions. Thank you.
Thank you, Dr. Freihofer.
Sandra Freihofer, American Medical Association. And I really thank ACIP for the thoughtful and methodical process that you've gone through and looking at this. And you've gone on record and weighed in. You had a weigh-in from the National Academy of Medicine, the American Geriatric Society, the Johns Hopkins Center for Health Security, the WHO. So that adds so much credibility to this process. I also greatly appreciate the transparency foundational principle that you mentioned. The American Medical Association did have an opportunity to weigh in on the NOMS recommendations, and we wanted to clarify that under the 4-phase approach, physicians and healthcare staff and private practices who are involved in direct patient contact and are therefore at increased risk of exposure we think should be eligible for vaccine in phase 1. And these physicians and healthcare personnel may not have access to the PPE that physicians and other healthcare personnel have in the larger healthcare facilities. I wanted to make sure that that the group was aware of that.
Thank you. Dr. Atmar.
Thank you, Dr. Romero, and thank you, Dr. Oliver, for a presentation of an outstanding framework. I think you've, set the groundwork for the really difficult work that is still to be done, which is further deciding how to roll out the vaccine to these different groups. And I want to echo Dr. Szilagyi's comment about trying to keep it simple to implement, and Dr. Hunter's comments about the importance of guidance. I know our own healthcare system has begun to struggle with, should there be vaccine available for our healthcare personnel, how that is to be allocated within the healthcare system. And so, I know we're racing against time to be prepared to do this, but there's still the very real challenge of trying to figure out within these groups how to further subdivide them if they will be so divided. But you've set a great foundation by which to begin this more difficult work, and I want to lend my voice of support and thanks.
Thank you very much. Are there any other comments? I just want to make sure, Dr. Hunter, your hand is still up. Dr. Freihofer, your hand is still up. Any other comments that you wish to make?
No, I'll take it down.
Thank you all. So if there are no other comments or questions, then we're going to take a 15-minute break. We'll be back at 1:15. Thank you.